There are feedback forms that are available in the lobby, and as I've mentioned before, and what people are doing is providing their questions through the using the question tab in the auditorium. And of course, during there will be opportunities during the meeting to look at the information that's available in the lobby, for example, the Kipler stall. So I'd now want to introduce the chair of the next session, session 2, and this is going to be a panel discussion. The chair of this is Dr. Farah Massoud. Now, I don't know if we've got something. Here we go. Yes. So Farah Massoud is a public health professional working as a technical officer at the Public Health Emergency Management Centre at GHD Infinet. Farah is spearheading a range of projects in the EMR, including strengthening event-based surveillance of respiratory diseases, supporting multi-sectoral coordination to strengthen prevention and response to future outbreaks, and elimination of specific neglected tropical diseases. And Farah is an active member of the MENA ISN since 2021. So I'd like to now hand it over to Farah. We will then see the results of the poll, and of course then we'll have the pleasure of seeing Dr. Meen back again as the moderator for the next session. So thank you, Dr. Farah.
Good morning or good afternoon to all participants attending the workshop today. My name is Farah Massoud and I'm a MENA ISN member, and I'm also a technical officer at the Public Health Emergency Management Center at GHD Infinet. And it is my absolute pleasure to be here today. Please allow me to welcome you to the second session, which is a panel discussion on respiratory virus pandemic preparedness. This is an extremely important topic because, as we have seen with the COVID-19 pandemic, it caused unprecedented and devastating impacts on the health and well-being of millions of people. And it has also disrupted health systems and service delivery in many countries. The COVID-19 experience presents an opportunity to build on lessons learned and be better prepared for future respiratory viruses. We know that pandemic preparedness is a continuous process of planning, exercising, revising, and translating into actionable plans. So it is important to hear from the panelists representing different countries on their experience and what the several factors that would make countries better prepared for an early response are. I will leave you now with Professor Amine, who is the MENA ISN Secretary, that will be introducing the esteemed panelists and moderating the discussions as well.
Actually, I would like to start with Professor Azmi Mahafza. So Professor Azmi is a professor of microbiology and immunology working in the University of Jordan School of Medicine. And we are privileged to have him here with us today in this panel discussion. So welcome. I would like to thank you very much. I would like to start with the first question. So in your opinion and in your experience, how was the healthcare setting in the hospital disrupted with the pandemic, and how do we structure our hospitals moving forward? So I especially ask this question to have an insight about the management of the COVID-19 patients, especially during the pandemic situation. Please.
Yeah. Regarding the first part of the question, the healthcare setting in hospitals was disrupted by the pandemic in most countries all over the world. Though to varying degrees. Under conditions of lockdown, patients were unable to reach hospitals, and the patient care was severely compromised in many countries. The COVID-19 pandemic has placed a sudden, inadvertent strain on healthcare services worldwide and brought in new challenges daily to millions of people, especially with respect to healthcare. And it also overshadowed the suffering of other substantial and larger segment of patients, the non-COVID. And this occurred in 3 ways. The first, the majority of hospitals were fully converted to COVID-19 care with an abrupt cessation of essential services to non-COVID patients who need regular care. And the second is that fear of contracting COVID infection at hospitals led many chronically ill patients to postpone or cancel their regular follow-ups. And the third is that, which is most neglected reason, is misclassification or handling of COVID and non-COVID patients. This had led to long wait for first medical contact, delay in workup, and prolonged turnaround time. Radical transformation which took place in healthcare system affected the ability to maintain high quality care. The practice of medicine changed more in weeks sometimes, as according to many physicians, than in several decades, especially in patient cancer care management, whether removal of surgical intervention before chemotherapy, or etc. Another distressing trade-off is that between patient need for procedures and the need to protect caregivers from infection and preserve hospital capacity. Because of the resulting resource constraints, and fear of infection. Clinicians and non-COVID patients deferred non-urgent visit evaluations, diagnostics, surgeries, and therapeutics. So the pandemic, in early pandemic, physicians and leading public health officials noted dramatic decline as well in non-COVID related emergencies, including a 60% decrease in patient myocardial infarction and strokes. While these postponements may have reduced the amount of unnecessary services used, they likely also caused a deferral of needed services, which many believe will lead to later hospitalization requiring higher levels of care, longer lengths of stay, and increased hospital readmissions, thereby furthering straining hospital inpatient capacity. Now, regarding the second part of the questions, which is address the preparedness of hospitals, it's essential in transforming situations like this of the existing infrastructure and capacity for changing situation without affecting normal patient care. Hospitals should be kept abreast with various coping strategies of other healthcare setups and learn from shared experiences of others. Every hospital, be it in urban or suburban location, needs to be prepared for any kind of unforeseen or foreseen pandemic. Now, a vigilant hospital emergency committee should consistently monitor existing infection control practices and prepare for any pandemic situation. The hospital response team should also make and enforce protocols in line with the directions of the government bodies. Healthcare reorganization of resources and manpower, establishing management protocols and specific patient pathways are all evolving with the continuously changing situation. So an epidemic or pandemic requires a health facility to alter its priorities and adapt its work routine to mount a coordinated systemic response to a rapidly evolving, potentially complex situation. And the COVID-19 has taught new lessons to healthcare providers and policymakers to adopt national and international guidelines and policies to develop tailor-made system solutions. That's
Yes, thank you very much. Actually, you have touched upon what we call the collateral damage, the damage that the non-COVID-19 patients actually experienced during the pandemic. So would you like to comment it a little bit more? Because actually every risk brings an opportunity with that. So were there any innovative approaches to take care of these non-COVID-19 patients during the pandemic?
Yes. Now, as you said, as the coronavirus pandemic focused medical attention on treating affected patients and protecting others from infection, the question that was raised, how to best care for people with non-COVID related disease. And for some, new risks may warrant reconsideration of usual standard care. For others, the need to protect caregivers and preserve critical care capacity may factor in decisions. The key challenges to any healthcare setup during emergency situations such as the COVID pandemic would be to rapidly address hospital preparedness and response tailored to the local population, societal influences, political factors with the existing infrastructure and workforce. Second, to adopt and moderate policies, standard operating procedures, and guidelines issued by national and international agencies, such as WHO, CDC, and the like. And those were tailored to make the local conditions for hospital and community. Issues that help to perform well include, but not limited to, the following points: a smart leadership with good teamwork, transdisciplinary team approach, contingency in terms of financial resources, manpower, and space availability, integration of various resources and coordination, optimizing the workforce, and uninterrupted supplies of commodities for quality care. It's critical that care is not focused only on the acute care of COVID-19 patients, but patients without COVID are also managed proactively, particularly those within time-sensitive and medically complex conditions who are postponing their care. This is important not only to sustain health and life, but also to preserve future hospital capacity. Drawing on key principles from operation management and applying a health system perspective for strategies were proposed by Song et al. In 2020 to facilitate care of non-COVID patients, even as hospitals are stretched to absorb waves of patients with COVID-19. These 4 strategies include innovative outpatient management to reduce demand and downstream bottlenecks. Teleclinics is one of the options. Proactive patient care by physicians, not waiting patients to ask for a care, is another issue in this regard. The second is combined essential non-COVID inpatient services across hospitals, and that to balance demand across hospitals. Public health officials should supply a version of the logistics strategies known as location pooling combining demands from multiple locations. And the third strategy is group hospitalized COVID-19 patients by their underlying clinical conditions, in which we place their COVID-19 patients who have serious underlying health issues with other COVID-19 patients with the same condition, which is cohort works in this regard. And the fourth, the last, is discharge patients into post-acute care based on COVID-19 status. We're sending patients to specialized post-acute care facilities based on their COVID-19 status will facilitate the discharge planning, improving patient flow out of the hospital for COVID-19 and non-COVID-19 alike.
Thank you very much. So my last question will be, are we ready for a next pandemic, either with a new variant of concern or with influenza? So what have we learned from this pandemic and how will we move forward for a pandemic state when it's needed again in full term?
Yeah, the literature is full of recommendations, especially CDC, WHO, etc. And by having a comprehensive emergency preparedness plan crafted to address health crisis and pandemics, healthcare facilities may better prepare to develop a quick, coordinated, and effective response while adapting the measures to the specific emergency situation that the health facility is facing. The COVID-19 pandemic, for example, has demonstrated the importance of infection prevention and control implementation at national, subnational, and facility levels to contain the emergence and re-emergence of infectious threats and for the delivery of a safe care. IPC plays a critical role in detecting, assessing, notifying, and reporting events and responding to public health risks and emergencies of national and international concern. The pandemic has also demonstrated the critical role of health system resiliency in providing essential health services and maintaining health systems functioning. IPC, in cases of search or research of an epidemic, goals are to reduce transmission of healthcare associated infections and thereby to enhance the safety of all who are present in a healthcare facility, including patients, staff, and visitors. The second is to enhance the ability of a healthcare facility to respond to an outbreak. And the third is to lower or eliminate the risk of the healthcare facility itself amplifying the outbreak. Now, the immediate action needed, and that's immediate within 2 weeks, to be taken in case of search or research or ongoing outbreak, is to coordinate incident command group to direct actions and cascade communications, manage safe flow of patient and staff, ensure safe care environment and remediate where needed, ensure personal protective equipment availability, optimal use, and universal masking, increase active screening, testing, physical distancing, and vaccination of health workers, and continue to assess and increase infrastructural capacity for safe management of patients, critical care, and delivery of essential health services. And finally, ensure ongoing training on infection prevention and control and occupational health and safety. First, pandemic preparedness is most effective if it's built on general principles that guide preparedness planning for any acute threat to public health. And the criteria, the bases are well known, and they can be referred to in many of the public health documents from WHO or CDC or other bodies.
Okay, thank you very much. So it was very valuable to have your inputs and experience in pandemic preparedness. Now we will continue with the other panelists and do another round of these 3 questions to get their responses. Thank you very much.
Thank you very much. Thank you. Nice to meet you. Thank you.
Dear colleagues, welcome to the panel on pandemic preparedness. And today we will be talking about the challenges that we have faced in patient care in our hospitals and the lessons we've got, hopefully, to build up resilient systems to care for both COVID-19 patients and also non-COVID-19 patients in a safe and effective way. And today we have 4 very distinguished speakers. First, let me introduce myself briefly. I'm Professor Dr. Mine Durstanröver from Ankara, Turkey. I'm working in Hacettepe University. I'm an internal medicine specialist and also a board member of the Vaccine Institute. And first of all, let me introduce you Professor Kilnani. Professor Kilnani is the chairman of the PSRI Institute of Pulmonary Critical Care and Sleep Medicine, and formerly professor and head of Department of Pulmonary Critical Care and Sleep Medicine in New Delhi in India. Welcome, Professor Kilnani.
Thank you.
And our second distinguished speaker is from Indonesia. Professor Dr. Samsu is an internist with a specialization in allergy and clinical immunology with a PhD, and he's working in the Faculty of Medicine of University of Indonesia. Welcome, Professor Samsu. And our third distinguished speaker is Dr. Jihan Elfana. She is a transdisciplinary practitioner and patient safety leader working in the Department of Quality and Patient Safety of Royal Hospital in Muscat and Oman. And she is working for providing a safe environment for the patients. Welcome, Dr. Jihan. And our first speaker is from Jordan, Professor Azmi Mahafsa, and he will be introducing himself as well. So here we will have 60 minutes in total for 3 rounds of discussion, and afterwards the panelists will respond to the questions from the audience. So if you have any questions, please use the chat box to type your questions, and we will be more than happy to answer those at the very end of the session. So let me first start with the first question. So in your opinion and in your experience, of course, how was the healthcare setting in the hospital disrupted with the pandemic, and how do we structure our hospitals moving forward? I especially ask you to discuss this question with regards to the care of the COVID-19 patients. So Professor Kimnani, to start with you, please.
Sorry, you'll have to repeat your question. I couldn't hear.
How was the healthcare setting in the hospital disrupted with the pandemic, and how do we structure our hospitals moving forward? I especially ask this to discuss with regards to the care of the COVID-19 patients.
Well, thank you. Firstly, thank you for getting me onto this program, very important program. So I was associated with this preparation of the pandemic right from the outset. As the COVID pandemic was announced and WHO announced it as a global emergency, I live in city of New Delhi, and we had actually, there was a 3-member committee, which was headed by Dr. S.K. Sareen. And we actually started preparing for number of cases and number of beds, number of ventilators and oxygen requirement right at the outset. If we get 100 cases per day, what we will do? If they get 500 cases, what we'll do? If we get 1,000 cases, what we will do? So accordingly, there were beds were allocated in various government hospitals, especially, and they were actually kept vacant for us as a part of preparedness. As the pandemic progressed, this became insufficient, and then subsequently, all the private hospitals were directed under the law to allocate X number of cases, hospital beds, and dedicate it to the COVID care. And as we progressed further, that also became insufficient. So as happened in the New York and other countries, some grounds, some public halls were allocated, and stopgap hospitals were prepared. So it was a requirement, but also there was a shortage of staff and medicines. So to circumvent that, nurses, sweepers, were asked to come for duty. There was a shortage of PPE kits. There was a shortage of medicine. There was a shortage of oxygen. All this was done on a war footing. And over an